Please go ahead. Thank you.
Good morning, colleagues. I'm Dr. Arvind on behalf of MCure Pharma and organizing team. I welcome each one of you for today's academic session on a very apt topic of management of ALL in infants. We are really grateful to Dr. M.B. Agarwal sir and Dr. Subha Prakash Sanyal sir for putting together the brilliant faculty, and the discussion also would be very stimulating for the audience. Without a further ado, it's now my privilege to introduce today's chairperson, Dr. Subha Prakash Sanyal sir. He doesn't need any introduction. He's the Director Hematology and BMT Services at Fortis Gupta Hospital, Mumbai. He has been the eminent hematologist, hemato-oncologist, and BMT physician with more than 2 decades of experience practicing in Mumbai. And with this, thank you so much, sir, for your time. And without a further ado, now I hand over the session to Dr. Sanyal, sir.
Over to you, sir. Thank you so much.
Thank you, Dr. Arvind. Just give me a minute. So very good morning to all. So today's topic of discussion will be the management of ALL in infants, which will be in a very niche field of hematology, I believe. Our eminent guest speaker is Dr. Suma TL from Bengaluru. This program is sponsored by the Mumbai Hematology Group and supported by the MCure Pharma. And the Perfect Square will be the team which will be helping the logistics throughout the meeting. So my special thanks to Dr. Keoud, Mr. Keoud Soni, Dr. Arvind Bilas, Dr. Manisha and team MCure, Dr. Yash Kalpesh and the team Perfect Square, all the executive committee members of the MHG Mumbai, our chief guest Dr. Babita Hapani from Rajkot, our guest speaker is Dr. Suma TL Bengaluru, and all our discussions who are themselves eminent hematologists or medical oncologists, and at last all the participants for sparing your Sunday morning. Next Saturday, 28th May, there will be an exciting talk by Dr. Lakshmi Nayak about the primary CNS lymphoma advances in 2022. There will be another talk on Sunday, 29th, late toxicities, including mental health and the fertility after treatment of Hodgkin's lymphoma by Dr. Andres from the Denmark. Today's discussions are Dr. Amita Mahajan, Dr. Anand Prakash, Dr. Chetan, Dr. Gauri Kapoor, Dr. Gara, Dr. Prashant, Dr. Rajat, Dr. Arora, Dr. Richa, Dr. Ritika, Dr. Samir, and Dr. Venkatraman. So Dr. Amita Mahajan is a very senior consultant in pediatric hematology oncology in Dr. Apollo Hospital, New Delhi. Dr. Anand Prakash is a head and department of pediatric hematology oncology BMT in St. John's Medical College, Bengaluru, far south. Dr. Chetan, associate professor pediatric oncology, Tata Memorial Hospital, Mumbai, in our city. Dr. Gauri Kapoor, director, department of pediatric hematology oncology, Rajiv Gandhi Cancer Institute Research Center, New Delhi. Dr. Niharindu Gara, a consultant pediatric hematologist, Department of Pediatric Hematology and Oncology, Tata Memorial Center, Kolkata, far east of the country. Dr. Prashant, consultant pediatric hematologist, oncologist, and BMT specialist in the Wadia Hospital for Children, Mumbai. Dr. Rajat, consultant pediatric hematology, oncology, BMT, KK Women's and Children's Hospital, Singapore. Dr. Ramandeep Singh Arora, senior consultant pediatric oncology, Max Super Specialty Hospital, New Delhi. Dr. Richa Jain, assistant professor pediatric hematology and oncology, Department of Pediatrics, Advanced Pediatric Center, PGI, Chandigarh. Dr. Ritika Khurana, Department of Hemato-Oncology, Immunology and BMT, Wadia Hospital for Children, Parel, Mumbai. Dr. Samir Bakshi, Department of Medical Oncology, Dr. BRA Institute, Rotary Cancer, All India Institute of Medical Sciences, New Delhi, and Dr. Venkatraman, Professor in Charge, Medical Oncology, Cancer Institute, Chennai. So guest speaker is Dr. Suma TL. She is a consultant pediatric oncologist, Department of Pediatric Oncology, Hematology and BMT, SCG Hospital, Bengaluru. Dr. Suma did her MBBS from Devaraj Arts Medical College, Kolar in Karnataka. This was followed by DCH from Karnataka Institute of Medical Sciences, Hubli, and DNB Pediatrics from Kovai Medical Center, Coimbatore. Subsequently, she did a fellowship in pediatric oncology from Kidwai Medical Institute of Oncology, Bengaluru. She worked as an ad hoc assistant professor at Kidwai Medical Institute of Oncology for a year. After this, she moved to Healthcare Global SCG Cancer Center, Bengaluru in 2016, where she has been working as a full-time consultant pediatric oncologist till date. Her areas of interest include hematological malignancy, childhood leukemia, lymphomas, histiocytosis syndrome in children, and other solid tumors in children. Dr. Suma is trained in bone marrow transplantation, and she's an active member of the Indian Academy of Pediatrics, IAP and IIP-PHO. Today, we are extremely blessed to have our special guest, Dr. Babita Hapani from Rajkot. I have one personal privilege to be in Rajkot just 2 weeks back, and I enjoyed excellent environment from the Rajkot, and I met a lot of oncologists and pediatricians there. So Dr. Babita is a medical oncologist and a hemato-oncologist, and he's one of the very senior medical oncologist, hemato-oncologist of the city of Rajkot. She's a director of Aruni Radiation Center, Rajkot. She's a practicing medical oncologist and hemato-oncologist for over 20 years at Pragati Multi-Speciality Hospital in Rajkot, and she's one of the pioneers in started that is all hemato-oncology and medical oncology services in that part of Kathiawar in the country. Earlier, she has worked as chief medical oncologist at MP Cancer Hospital, Rajkot. She did a DM in medical oncology from Gujarat Cancer and Research Institute, Ahmedabad in 2000, which is a very prestigious institute. Earlier, she did MD in internal medicine from MP Shah Medical College, Jamnagar in 1995. So I'd like to invite Dr. Babita to just give some words of wisdom to our young students, fellows, so that we can understand the importance of the hematology and hemato-oncology and the medical oncology. Thank you, Dr. Babita.
A very hearty good morning to all of y'all. At the outset, I would like to thank Dr. Subha Prakash Sanyal for such a wonderful introduction that he has given me. I also would like to thank Dr. M.B. Agarwal sir for this wonderful initiative that he has said that I could be able to interact with all of y'all. Like it has been mentioned that I have been practicing for the last 21 years at Rajkot. But when I joined for DM oncology about 25 years back, hematology was not much of a subject. There wasn't much that we could do for the patients. Treatment was very conventional with conventional CT, and in Ahmedabad, in Gujarat Cancer Institute, we had just started BMT. So the survival rates were not very good, and we were unable to manage very well all the toxicities and other issues. People were also not very willing to join, to take treatment in those days. But that was again, let's say, 25 years back. Now so much has changed. So much has changed. Better lab equipments, better laboratories which are helping us with flow cytometry, with molecular genetics, with everything else. Now we have better drugs, right? Anything from TKIs like imatinib, which made a dramatic change so many years back, to CAR T cell therapy now for lymphomas. So much has changed over the years. Even in BMT, now we know that in the stem cell transplant, better selection of patients and better management of toxicities have been helping us, in creating a survival rate which was a measly 20% that time to about more than 80% now. So what I would like to say is that since there is so much available now, my thing to all young doctors, hematologists who would like to practice hematology, I would like to say that hematology now is a very, very good branch with immense potential. Now there is better treatment available, better management of everything else. Now we have better setups. But again, we have all this in the niche centers of the country. These smaller centers in the country also need better hematologists, good, well-trained doctors. We know that something as simple as iron deficiency anemias are also not diagnosed at the right time and not treated adequately. So we have a huge population of young women who are iron deficient for no reason. So I think you guys can make really a big difference, and I would encourage that now hematology should be taken up because it is much more rewarding nowadays. Well, with this, I would like to thank you all for having been able to interact with you. I thank Agarwal sir again because it's always such a pleasure to listen to him when he teaches hematology. Again, my thanks to Dr. Suprakash Sanyal for this wonderful initiative. And it was nice to have you, to host you in Rajkot, and you had given such a nice lecture that day also in the conference. Thank you all, and and have a good day. Bye.
Thank you, Dr. Babita, for your kind introduction. So now, Dr. Suma, you please start and go ahead with the very niche branch of hematology what we'll be talking today.
Thank you, sir. Very good morning to all of you. I have to mention that I'm missing Dr. Agarwal today. I hope to interact with him soon. And I'm very thankful to all the discussants, and I hope it will be a fruitful discussion today. And hopefully I too take back something very useful for my practice from all of you. Just sharing my screen. Is my screen visible?
Yeah, very much.
Most of what I would be speaking today, I have taken the inspiration from Dr. Niharendu. I heard his lecture in the FOCON, I think December last year. And sir, I must say, it kind of interested me, the topic, and coincidentally we had an infant at the same time in our department, and it kind of made me look more deeper into the topic. Leukemia, we know we don't see much of infants with leukemia, and it's a very unique presentation because it's a vulnerable post, and the response to current therapies is poor, and also because these special population have a unique biology. They often present with high WBC count, hepatosplenomegaly, CNS involvement at the time of presentation, poor response to steroids, and the very classical feature being absence of CD10 on the flow cytometry, and some portion of patients even have skin infiltration. They have a very poor RFS compared to children of the older age group, even with the use of maximally intensified standard therapy regimens that are available in today's date. I could not find the Indian statistics which could show me the incidence of acute leukemia in infants. So I have taken the quote from the US, where they see about 160 patients per year, and of them 90 patients are ALL and 70 patients are AML. This is a unique population where the incidence is more common in females than males. The classical biology that we see in these children, the MLL rearrangements, does not account for a much population in the pediatric ALL population overall, but 70 to 80% of infant ALL patients have these genetic abnormality. We now know that it is the initiating and the driving oncogenic event. It dysregulates epigenetics and causes changes in the transcriptional programs. The classical translocation 411 that we see most commonly in this infant ALL population is a BALL, which is CD34 positive, CD19 positive. It could be most often CD10 is negative, with co-expressing aberrant myeloid markers like CD15 and 65. The addition of neuroglial-2 antigen, which is a chondroitin 4 sulfate, it's a proteoglycan which is present in the transmembrane area. If picked up on the flow cytometry, almost always indicates that there is an MLL rearrangement. When present, these patients can, up to 50% of them can present with CNS disease either at the time of diagnosis or at the time of relapse. Very uniquely, T-cell disease is not very common in this population. It accounts for less than 5%. We know that, as such, this the age group, age less than 365 days, they're immature, organ-wise, and they also have immature patterns with respect to their immunoglobulins and TCR gene rearrangements. These are less common in the older children. When looked closely by Hansen et al., especially in the Interfant 99 study population, they observed that these are oligoclonal and the immunoglobulin heavy chain PCR rearrangements are more commonly seen in the infant group, whereas the rest of them, that is the IgK, TCRB, TCRG, these are very rare and they're seen only in less than 20% of them. When looked deeper, the MLL AF4 and MLL ENL, which I will be describing in the next few slides, they show immature rearrangements, whereas the MLL AF9 show mature rearrangements. So from this picture, one can notice that the just the age group of 0 to 365 days, when subdivided into different ages from 0 to 12 months, the incidence of the different translocations changes. So here, what you can notice is as the age goes on increasing, the MLL rearrangements of different types go on decreasing, and the non-MLL group, increase in number. Probably that's why the outcome of these patients improves with age. The most common translocation, which is the MLL AF4, is commoner in the 0 to 6 months age group. That is why they're again described as the high-risk population among this already high-risk, population. And among these translocations, when looked at the flow cytometry, we can notice that the CD10 positivity goes on increasing as the age increases, and more and more children are positive for CD10 in the age, MLL negative population, whereas in the MLL rearrangement groups, pro-BALL is the more common type. On flow cytometry, the blast population here, which is depicted in blue color, it is easily noticeable that they are CD10 negative, and they can be CD19 and 34 positive. And if neuroglial-2, the marker is available and it is tested, and these patients, if found to be positive, they're most often likely to be MLL rearranged. On FISH, the report, when the cytogenetics report, when we get from our cytogenetics lab, most of the genetic information can be available from the karyotyping, but we know that time is much later, but FISH report can be available within 2 to 3 days. There are two types of probes that are available: the dual color break apart probe and the dual color fusion probe. In the break apart probe, what we can observe is the derivative 4 and derivative 11. That's the most common translocation. Derivative 11 is orange in color and derivative 4 is 11. So on FISH, when one looks at the metaphase or the interphase part of the cell cycle, if they are separated, then we know that there is an MLL break. On the dual color, dual fusion probe, which is more specific to the rearrangement. So in this, we can pick up the different MLL rearrangement. So if the probe is available with the lab for the different translocations, and when done, they will be seen as a fused signal in the dual fusion fish study. So coming to the biology, now it's very well established that the germline MLL mixed lineage leukemia gene, that also known as the KMT2A, which is the methyltransferase gene, located on the 11q23 locus on the 11th chromosome. It's also required for normal hematopoiesis and expression of the FOXA cluster gene. It's required for a different array of events in embryogenesis, apart from hematopoiesis. When this rearrangements are present, the most are likely to be found in association with de novo infant leukemia and therapy-related leukemia. Here, there is a reciprocal translocation between the MLL and the translocation partner gene, which results in a production of a chimeric protein. So the translocation occurs at the N-terminus domain of the MLL gene and the C-terminus domain of the partner gene. So this major breakpoint cluster gene is located between the MLL exon 9 and the intron 11 in 93.5% of the patients. The 6.5% of them, this BCR might be found in the outside this purview. It's a 430 kilodalton gene consisting of around 36 exons and 3,969 amino acid residues. Now we know there are more than 94 translocation partner genes which combine with this gene, resulting in various fusion proteins and clinical presentations. The normal function of this gene, this is the N-terminus and this is the carboxyl terminus. So the N-terminus is required for the enzymatic, they read the bind and read the chromatin signatures, whereas at this end, the major functions are acetylation and methylation. The area of interest is this portion, the small tiny portion next to the plant homeodomain, wherein the break happens and then the translocation partner gene binds over here, and then the further cascade of events happen. When TASPase, which is a protease enzyme, acts upon this area, so what exactly happens is this the PHT part of the gene is further broken down into 4 domains, PHT 1, 2, and 3, and this is called the enhanced PHT 3, and which is connected through a bromodomain to another enhanced PHT 4 part of the gene. So what exactly happens here is this portion undergoes dimerization, and once dimerized, it is supposed to either read the histone 3 K-methyltransferase gene part of the protein, or binds to the cyclophilin 33 or the propyl peptidyl isomerase enzyme. So either of the events are supposed to take place. So what happens at this level is, once there is a translocation or a rearrangement, there is an MLL switch, which results in one of the events. So either there is activation or repression, and that thus further leading to a cascade of events. So in a physiological situation, it is responsible for promoter activation or inactivation events, and then the transcriptional memory system maintenance. Whereas in a translocation scenario, the entire system gets disconnected. So there is promoter hyperactivation, there's formation of aberrant histone codes, and the cells end up acquiring their stem cell features, and the entire transcriptional memory system is deranged. So there is a thought process about whether the MLL gene alone, rearrangement alone, is enough for resulting in overt leukemia in these patients. So they have tested a lot of healthy newborn babies for this particular gene, and followed them up till they presented with any leukemia features, but not all of them had leukemia. So then the thought process of whether there is a second hit theory necessary for the presentation with overt leukemia. Most of the work is done by this Rolf Marszalek. A lot of articles written by him wherein he describes that there was a study conducted on identical monozygotic twins where they shared the placenta, and then if the one child that had the MLL rearrangement and the other twin also was having a concordance rate for leukemia of up to 100%. So the theory here being whether FLT3 mutations are necessary, RAS mutations, or any epigenetic events, or an array of other genetic events that can take place with resulting in overt leukemia on a pre-existing MLL clone. So we know that the latency is very short. So the child has to present with leukemia within 1 year of life. So the latency period is not sufficient for this theory to be true. A lot of groups have studied KRAS mutations if they hold any reason for this event. But this, when studied further, was seen to have been lost at the event of relapse. So that is not a tumor driver. And FLT3 here, it is not the mutation, but the increased transcriptional expression, which is the event that happens for association with the already pre-existing MLL clone. So this again has been looked at as a novel target for adding to the already existing chemotherapy backbone, which I will be describing further. So we know now that there is a MLL gene which has a translocation partner gene, then the resulting fusion proteins, and then the cascade of events that happen and resulting in an aberrant gene expression profile and eventually leukemogenesis. The Mayer article published in Leukemia Journal in 2013 has looked at roughly about 1,600 patients, both adult and pediatric, where he described the MLL fusion leukemia. For us, the area of interest is this part of the picture where the different translocation partner genes have been studied and their incidence in both pediatric and infant leukemia. In the infants, the most common translocation partner gene, as I said, is the AF4, followed by AF9 and ANL, whereas in the AML, it's a different scenario. The fusion partner genes are different. So they are both nuclear fusion partner genes and cytoplasmic fusion partner genes, and hence there is a different event that happens in when the different translocations are discovered on FISH analysis, and probably that is why the different clinical presentations and different responses to treatment. The most common 4 partner genes that are observed in most of the cases, like 93% of them, almost half of them is now the AF4 translocation partner gene, which is renamed as AFF1, MLLT1, which is the ANL partner gene, MLLT3, which is the AF9, formerly known, and MLL10, which is the AF9. So in that order, and in all the studies, even in the cooperative groups, this is the similar incidence has been noted. Of one small mention is the novel NUT-M1 fusion partner genes, which have been noted in the specifically in the pediatric BALL population, more so in the infant group. The incidence is not too high, but it's roughly between 0.26 to 0.6% in the infants, in the pediatric population, whereas in the infants is up to 5%. Why I would like to mention this is this population, if noted on RNA sequencing or the next generation sequencing, they do well. They have an excellent outcome. And even in patients who have, and also even this gray line represents the wild type NUTM1 and the KMT2A translocation, and this dark black line represents the NUTME1 rearranged population. You can see here that they have an excellent outcome. So these patients can be de-escalated and treated on the regular standard chemotherapy protocols. Though they are infants, they don't have to be treated too aggressively. Various cooperative groups have now shown that the sensitivity of cytarabine is very marked in the infant population. So RSE, when given to the patient, crosses across the membrane with the help of the human equilibrative nucleoside transporter 1 protein, and once inside the cell, it undergoes events of conversion. So the dose limiting enzyme here present is the deoxycytidine kinase, which helps in conversion of RSE into RSEMP and further CTP, which gets incorporated into DNA and eventually resulting in cell death and apoptosis. Infants as such are noted to have a high concentration of the human ENT1 gene, up to 3.3 fold higher than the rest of the pediatric population. And hence the lethal concentration 50 of RSE achieved in infant population is much higher, and the RSI-CTP, which is the active nucleoside analog, which is responsible for incorporation into the DNA and further cell death, is also higher in these specific population when compared to pediatric population. When in the same article by Stam et al., they have also published that the mRNA of both HENT1 and deoxycytidine kinase have been studied. The lower the concentration of DCK, the better LC50 values are attained. And if DCK values or DCK mRNA values are found to be higher, it correlates very well with resistance to treatment with cytarabine and hence poor outcome. So in the past, the infant population was not treated specifically, mainly because the incidence itself is so rare. And it was a known and understood thing that they have poor outcome because of their high-risk features. And they were simply escalated to high-risk arms within the trials and looked at carefully whether they did well on those high-risk arms, but with not much success. So that led to the laying of foundation of infant-specific protocols with a proper stratification system for the infant population. So over the years, we have learned a lot about management of ALL. So somewhere in the 80s is when the main realization of infant ALL population as a poor prognostic population and an unfavorable age group was identified. And over the years, they were initially treated on non-specific protocols, but studied as a population, trying to look at their outcome and survival. And that led to the formation of cooperative groups, the North American group in blue, the Japanese leukemia study group in orange, and the Interfen group in green, which have evolved now, giving us more data as to how to treat this specific population. So on this chart, what I would like you to understand is that initially they had a pilot study where they just looked at retrospectively as to how this age group did, and the CCG kind of looked at it and said that, okay, they initially looked at only 27 infants and these don't do well. The EFS was on 4-year EFS was only 36%. So in CCG 107, around 98 infants were studied between 84 and 88 with a dismal outcome of 32.6% of 5-year EFS. And what we understood that we need to come up with better protocols for this population. In CCG 1883, in the late 80s and early 90s, a huge number of infants were taken up who achieved good CR rate at the end of remission, but eventually their 5-year survival, EFS and OS, were not great. So here what they compared is the CCG 107 added high-dose methotrexate with intrathecals, and as soon as the child was about the age of 1 year, they were pushed into radiation, and they were to receive radiation, craniospinal irradiation of about 18 gray. Whereas in CCG 1883, they tried to add high-dose Ara-C2 to the already existing backbone, and they were able to achieve a remission of 94.1%, but eventually similar outcome was seen in both the trials. The one point that emerged from these two trials was that translocation 411 is the adverse prognostic factor, along with age less than 6 months, CD10 negativity, and failure of morphological remission at the end of day 14. And the children who had a high WBC count also posed a problem. So now moving on, the CCG 1953 trial in the late 90s and early beginning of the millennium. So they analyzed about 115 patients. What they did here is change the dosage. The dosage was according to body surface area. In these two trials, they used daunorubicin as a continuous infusion in over 48 hours in the induction, whereas in the 1953 trial, it was decreased because there was high toxicity in these two trials. And the CCG 1953 mainly proved that there was no benefit of adding HSAT as a treatment option, routine treatment option for MLL rearranged patients. The pediatric oncology group conducted mainly 3 trials on the current, the merged 631 trial that has been completed. So initially, they also used a combination of drugs, cyclophosphamide, vincristine, citrobine, prednisolone, alternating with teniposide and high-dose methotrexate, high-dose Ara-C, IV 6MP. All these drugs were used in combination and rotating cycles. They just showed very modest improvement in outcomes, and eventually the early relapse, that is within the diagnosis of 24 to 48 months, there was high relapse rate, and also the need for intensifying post-induction chemotherapy was insisted upon. POG 9407 progressed in 3 cohorts. There was cohort 1, 2, which was conducted between 96 to 2000, and then cohort 3. So the cohort 1 and 2 were mainly on the CCG 1953 backbone. So here, again, what they proved is that there is no use of using HSCT routinely for these patients. Whereas the main of mention is the cohort 3. Here, the treatment was intensified to just 46 weeks. This cohort received no steroid prephase. There was sudden tapering of steroids after day 21. So they randomized into 2 arms, which is dexamethasone arm and the prednisolone arm. And again, further randomization based on daunorubicin, short infusion and 48-hour infusion. So in the group which had 48-hour infusion of daunorubicin had high mortality with no benefit showing in overall survival and EFS. And of notice is there was no cytarabine added in the induction in the P9407 cohort 3. The Japanese group, on the other hand, have had better results compared to the North American group and even the Interfan group. They were the first to use risk stratification based on MLL rearrangement. They conducted 2 trials in the MLL 96 and 98 trial. the only caveat here is that theirs is a homogeneous population. It is just Japan, and they have racial wise, they were a homogeneous population. And what they were able to achieve here is the patients who had germline MLL noticed on the FISH analysis did better, and they had they did better with just chemotherapy alone and had a EFS of up to 95%. And they were also the first group to realize that the relapses were happening early, and there is no point in keeping these patients, treating them repeatedly based on either MRD or morphological remissions and then taking them up for transplant. Better to transplant them early. So they had a median time period of about 4 to 6 months, within which, if the donor was available, matched donor was available, they took them up for transplant. The new trials, I will be discussing them separately. So coming to the present, now we have the 3 main collaborative groups covering almost the most of the globe. The Children's Oncology Group, which covers the North American countries, and the Japanese Pediatric Leukemia Lymphoma Study Group, and the Interfend Study Group. All of them have different features for risk stratification. As you see from this picture, of mention is the Japanese group, which do not take the WBC count for risk stratification. The low risk group is common in all of them, which uniformly having comparable survival rates. The high risk group are different population, mainly based on their age and WBC counts in the COG and Interfend group, whereas here their WBC count is not taken for risk stratification. The Interfend study group was spanned across many countries and many cooperative groups within the continents and many institutions. So probably that's the reason the results are also different, because it's a collective result of all these institutions. Therefore, they came up with the Interfend induction, which is now followed almost all across the globe, which has a steroid-free phase followed by dexamethasone given over 4 weeks and then tapered. 4 doses of vincristine, which we started along with cytarabine from day 8 to 21, daunorubicin given on day 8 and 9. Elastogenase, the protocol has suggested to use conventional elastogenase, but different groups use even pegylated elastogenase. Intrathecals given according to age, and then extra intrathecals if they are found to be CNS involved, and bone marrow evaluation at different time points during the induction. So where the cooperative groups vary is in the post-induction. In the Interfend 06, they were the first large group which kind of emphasized on MRD being the post-induction approach, based on which they were able to propose the better outcomes for the population which were end of induction MRD negative. In Interfend 06, they were randomized into protocol IB, which is taken from the BFM. The same cyclocytrabine 6MP consolidation. This is predominantly a lymphoid consolidation. They compared that with the myeloid-based consolidation for a randomized group of children with cytarabine, daunorubicin, etoposide, followed by mitoxantrone, cytarabine, and etoposide. In the COG, the current completed trial, the 0631 trial, which used FLT3 inhibitors in the post-induction approach, the results which I will discuss shortly. Whereas the Japanese group didn't have any randomization as such. Their only main randomization was based on MLL rearrangements, whether they had it or didn't have it. The transplant was offered to all high-risk patients in the Japanese study, whereas in the Interfend, it was based on MRD and all high-risk patients. And COG, they didn't really look at transplant as an option, but it was retrospectively evaluated. So the Interfent 99, which was the first large group, almost having 481 infants, was based on the steroid prephase. Based on whether they had good response or poor response, they further underwent randomization. So these children went on to receive an Interfant induction followed by MARMA, which is high-dose methotrexate and high-dose Araci combination consolidation, and followed by reinduction, which had 6 drugs: vincristine, citrobene, cyclophosphamide, thioguanine, dexamethasone, and daunorubicin with aspergillase. After which they were randomized into 2 arms. This study mainly looked at whether this late intensification was necessary. So vincristine was added to this consolidation drugs, and one portion of them received that, followed by maintenance for a total duration of 104 weeks. Similarly, on the poor risk group. But of course, there was an option of transplant if the donor was available for the high-risk patients at the end of the reinduction. So this is the these are the drugs given in different courses of Interfent. So the incidence of MLL gene rearrangements was very similar. The most common one was a 411 translocation, roughly 50%, and the rest of them accounting for the rest of the population. And around 21% patients didn't have any rearrangements. So analyzing the data, it's easy to understand that the age group less than 6 months had poor outcome, which was statistically significant, and WBC count of more than 3 lakhs was also statistically significant. Children who didn't have CD10 positivity did not do well, and germline MLL patients did really well with conventional chemotherapy. Whereas there was not much statistical difference among the different translocation groups. So here the around 481 patients which were eventually evaluable. There were 21 deaths in induction. 11 patients were resistant to chemotherapy. 9 of them who died soon after the end of induction. They didn't last till they could receive any transplant. Deaths in remission is what worries. Around 13 patients died, so that's roughly around 2 to 3%. So 94% of them were able to achieve remissions. When there was relapse, it was 34%, a total of 163 patients. Bone marrow relapse isolated was the most common relapse, and 5% of them combined, and the rest of them isolated CNS. So of the 37 patients who achieved induction remission and had transplant, there was no significant difference between the patients who had transplant and then were continued on chemotherapy alone. So the Interfent 99 was not able to prove that transplant was a good option for these high-risk patients. And definitely this late intensification course with high-dose Araci and high-dose methotrexate was not useful. So this was dropped in the further Interfent trial. And most relapses occurred early. So that means we need to do something about our post-induction approach. We have to intensify the treatment here soon after induction. At that time, the comparison was done with the Interfent 99 trials, and these were the trials just then completed or which were going on. So of interest is that the Interfent was similar in results compared to most of the other trials, compared to the POG trial, slightly better, given that that was a trial which was specifically looking at infants as a population. Moving on to Interfent 06, what they did is they adopted the plant from the Japanese group, which is to base it on MLL status. Germline patients were classified as low risk, and they received the Interfent induction, and the entire schema was MRD based. flow cytometry based where it was available, and transcript based. So that is why there is a heterogeneity in results in this study. So the further low risk patients received the BFM type of consolidation, then MARMA followed by Octodad, and then they went on into maintenance with 6-MP and methotrexate. Whereas the high risk group and the medium risk group were again randomized to receive either lymphoid based consolidation or myeloid based consolidation, and the reintensification was similar. So if there was a donor available and these patients were found to be MRD positive at time point 5, they were taken up for transplant. And for transplant, the drugs that were used were busulfan, thiotepa, and fludarabine. So analyzing these results, you can see that there is not much difference between 99 and the 06 trials. Of course, it was a much bigger group and more infants were studied, but not much change in the EFS and OS in results. And the randomization between protocol 1B and AD, that is the myeloid and lymphoid consolidation, did not make any difference. The 6-year EFS and OS was better for the low risk group, which was by then confirmed from the trials that were running at the same time. The high risk group did dismally. So they concluded that the germline KMT2A did better. The same prognostic factors fared good for stratification even in 06. What was understood from this study, which was a really large compilation of patients, that MRD diagnostics can be used for risk stratification and treatment allocation. And they have proposed that the genomic breakpoint fusion sequence is the preferred MRD target if the facility is available. And the negative MRD, if achieved at the end of induction, is the strongest predictive factor for patients who were treated on lymphoid style of consolidation, but not for the myeloid type. So if the myeloid type, if they didn't do well, they were eventually also known to not have a great, EFS and OS. Whereas at the end of consolidation, if they were still able to achieve negative MRD, it was the strongest predictor irrespective of the type of consolidation that was received. So looking at these graphs, what I was trying to say, at the end of induction, if they achieve a negativity, the blue line, they did well. And they, at the end of protocol 1B, if they were negative, they also did well. Around 78% of them even had a good EFS. Comparing the protocol I1B and the myeloid and lymphoid type of consolidation, it's easy to notice that the myeloid type of consolidation was not good. Following up these end of induction negative patients till their eventual outcome, if they were negative, continued to be negative, they did well, having a good EFS on the protocol IB type of consolidation, whereas on myeloid consolidation, they didn't do so well. And those are the results for the intermediate risk and the high risk patients, not great. The Japanese study group, they recently concluded MLL 10 trial. It didn't used only one factor, whether they were germline or rearranged patients. All of the germline patients had regimen A and regimen B for the rearranged patients. What the Japanese did is up to 24 to 26 weeks of treatment, these patients were hospitalized. They received supportive care and constant monitoring. When indicated, they also received antifungal prophylaxis and antibiotic prophylaxis. And probably that's the reason they also ended up having better outcomes. So this was regimen A, which was given for the germline patients. What you can notice is that there's no cytarabine in the induction, replaced by cyclophosphamide. And they have rotating cycles of chemotherapy in the maintenance. Other than that, more or less the chemotherapy is similar. Whereas in regimen B, there is cytarabine in the induction for 14 days, followed by largely interferon based style of chemotherapy. So comparing these groups in both the MLL10 and the interferon 06 trial, the most striking feature that one can notice is that the intermediate risk group did really well in the Japanese study, and also the high risk group, whereas not much difference in the germline low risk group. So till date, from the cooperative groups that have been concluded and for whom the data is available, Japanese group publishing their MLL10 data is the the best results that are available. The overall survival EFS of 71%, which is the highest in compared to all the other collaborative groups, and the death in remission was very less. And they also transplanted a large portion of patients. Probably that's why the results are better. So looking at the MLL10 results, why they are better than interferon 06, there can be three reasons. They extended their supportive care. They had an early intensification soon after induction with high-dose RSE, and there were no early deaths in CR, largely probably because they were hospitalized and monitored constantly. And the high-risk criteria was different for patients who had to be taken up for transplant. They did not look at the WBC count. They looked at age at less than 6 months and the rearrangements. Almost 50% of the patients had transplant, and they are alive. 67% of them are alive in remission. Whereas in the interferon 06, 76 of them were high risk, and that was about 111 patients who eventually ended up having transplant from the total population, and the overall survival was 44%. There are also factors to be looked at with respect to drug dosage. What the Japanese did is to use full dosage for the age groups 4 to 12 months. And whereas the interferon group still used dose modified chemotherapy regimen for treatment. Probably that's also the reason why they did better. So is transplant a real viable option for patients with high risk features alone, or whether any changes in the stratification need to be done? So we know that age less than 6 months and MLL rearrangements are poor prognostic factors. Is a transplant at CR1 an option? So the first group to look at it was Pugh et al. In North America. They looked at their then available results in the 90s, and they felt that transplant really was not a great option, because at that time it was not separately randomized and compared again head-on one-on-one with chemotherapy. Later, the Marco et al. They looked at infants who received transplant in CR1, and it was 71% EFS for all patients who received transplant, and 50% for patients who had MLL rearrangement. So that's a really good result. And then Murray et al. Also looked at infants who, but that was a small, tiny population. Of the small number who received the transplant, 75% overall survival could be obtained compared with the patients who received chemotherapy, achieving overall survival of 60%. So further moving on, Jacobson also looked at around 16 patients who were treated with transplant in CR1, achieving 75% of EFS. And all these patients had MLL rearrangement. So in the Japanese group, as I was just mentioning, so this is again data from their 96 and 98 trials. We now have the results from the MLL10 trial, which proves that if transplant offered early for this, the high risk population in the already high risk, infant group, they do much better with the transplant at CR1. So there are several novel approaches that are coming up with the availability of target therapy. The COG, the AALL0631 trial looked at FLT3 inhibitor lestrotinib on a pre-existing chemotherapy backbone adopted from the P9407 trial. So what they wanted to know if this population did better when lestrotinib is added post-induction. So the standard risk group were the germline KMT2A, which did not receive any lestrotinib. Among the intermediate and the high risk group were further randomized into Arm B and Arm C. Arm B did not receive any lestrotinib and Arm C received lestrotinib. Lestrotinib was again given in two phases, on the safety and activity phase and the efficacy phase. The dose limiting toxicity was looked at, roughly 4 to 5 milligram per kg per day. So they wanted to look at either de-escalation to DL0 or escalation to DL2, depending on patient's response. If the dose was modified to more than 75% reduction, then those patients were removed from their eventual results. So in these graphs, one can notice that there was not much difference in the EFS and OS among the Arm B and Arm C patients, both in the intermediate risk and the high risk groups who received lestrotinib in the Arm C regimen. Various reasons have been proposed for why it could not be a success, and the trial could not come up with better results, except for the fact that it provided a forum for a novel agent to be added on a chemotherapy backbone. The drug, when it was started in 2004, when by the end of the trial, the drug was reaching its expiration date. So there were some technical issues. So they could not really assess the results properly, and it was closed for accrual. And hence, we now know that the addition of this drug was probably not useful. They also looked at whether the other FLT3 inhibitors like quizartinib could be used, or maybe better results could be obtained, which is yet to be seen. A lot of novel agents and target therapy agents are being used in the pre-existing infant chemotherapy backbone. The addition of demethylating agents like azacitidine, decitabine, histone deacetylase inhibitors like vorinostat, panabinostat, the DOT1 ligand inhibitors, all these are in preclinical and phase 1, phase 2 trial phases, and are being evaluated. We have now more data about blinatumomab from Dr. Ajay Vora and group from the UKL study group, and now we are looking more at target therapy for this population. Blinatumomab has been proved to be a useful drug for patients in pediatric ALL, precursor BLL2. So what this trial is trying to see is whether this infant population can benefit from this drug. We know that this CD19 antigen is not uniformly expressed in the rearranged leukemias. There is this possibility of immunological class switching that could happen when the CD19 is targeted, class switch from lymphoid to myeloid, and then this patient population becomes further resistant to any more chemotherapy or any more treatment. The drug inotuzumab is also being looked at, but the CD22 expression again is not uniform in these patients, and hence it might limit the activity of inotuzumab. The UKL Infant 2021 trial launched recently in August 2021 is looking at the usefulness of blinatumomab based on the outcome of 11 patients that they studied not as a separate pilot trial, but from their, the ALL 2019 and 2011 trials. They looked at these patients 11 infants who were treated on interferon 06 induction. All patients had KMT2A rearrangement. 7 patients received Blina and 4 received them at the as a first line because they were either resistant or refractory to disease, having refractory disease. Of which these 8 patients who were either in MRD positive at MRD positive CR, the median MRD was around 0.2%. And in these patients, the AFS was better and there was improvement in the overall 3-year survival. So these are the 11 patients that they studied, and around 6 patients continued to be in CR. 7 patients continued to be in CR after receiving Blina. So this recently launched trial is now looking at incorporating Blina into the chemotherapy backbone. So at induction, all infants receive interferon type of induction at the availability of the MLL status. If they're found to be germline, they at the end of induction, they go on and they receive a much moderate chemotherapy compared to the interferon post-induction chemotherapy, because we know that the germline infants do better, and probably we can look at de-escalating treatment for them. So this treatment would be MRD stratified. The further treatment will be based on either regimen B or regimen C UKR or the ongoing altogether trial. So after the time point 1, the medium and high risk patients would end up having a DEXA based pre-Blina consolidation, and then they would be further randomized at time point 2 to MR and high risk groups. The MR groups have to receive a minimum of 2 Blina cycles, followed up by Octodad, and then they go on into maintenance. Whereas the high-risk groups, while they are waiting for either enrollment into the CAR T cell or the hematopoietic stem cell transplant arms, they receive 1 cycle of Blina, and then the further restratification is based on their MRD post-Blina 1 cycle. So if they're still MRD positive, they are considered for CAR T cell therapy. If they're negative, they're taken up for transplant, depending on the availability of the donor. So in the pre-Blina consolidation, there is dexamethasone, which is given over a week and then tapered, and 2 additional vincristine doses, and on day 12, the MRD is done, and they're further stratified. So the Blina cycle 1, the initial 7 days, they receive about 5 microgram per meter square of Blina, followed up by 15 microgram per meter square. And then they, at the end of this, they receive only 1 week gap, because we do not want to leave these patients with no treatment. So the Blina cycle 2 is followed up within 1 week after this. So a lot of groups are also looking at bortezomib as a valuable contributor for treatment in infant ALL population. We know that this drug is very useful in a relapsed refractory setting. The St. Jude's group, Gruber et al., have looked at whether this drug can be added to the induction backbone, and with its ability to induce endoplasmic reticulum stress-induced apoptosis, the study is trying to look at whether this drug can add to any improvement in post-induction MRD when used along with vorinostat. And this trial is still, it's active but not recruiting. We are eagerly looking forward to the results of the trial. A lot of epigenetic agents are available, like DOT1 ligand inhibitors, the BET inhibitors, demethylating agents, HDAC inhibitors, and the RAS pathway MEK inhibition agents are also being looked at simultaneously. The disruptor of telomeric silencing 1-like protein, the DOT1 ligand, is a histone methyl transferase enzyme, which is present in humans. And this is the one also necessary for the H3K79 methylation, which is a very inherent property of the MLL gene activation in physiological state. So the pinometostat, the drug EPZ 5676, is a part of a current trial, which is being added upon to standard chemotherapy in treating patients with newly diagnosed AML who have MLL gene rearrangement. The bromodomain inhibitors, OTXO15, it specifically binds to the BRD2, BRD3, and BRD4. If you remember this, the bromodomain is the main connection between the enhanced PHD3 and PHD4. So when interfered here, it can completely disrupt the gene transcription and further leukemogenesis. So this drug is in phase 2 studies, given as ATMG 14 days on and 7 days off schedule. Again, we're looking forward to the results. The deacetylating agents like penobinostat, vorinostat, romidepsin are particularly synergistic with cytarabine and are being used in rearranged leukemias. One of them is already being studied by the St. Jude group. MEK inhibition, the drugs used are selumetinib and trametinib. As I mentioned earlier in the leukemogenesis hypothesis, RAS mutations are not the drivers. So they are subclonal and they're unstable and they are lost at relapse and even between diagnosis. So they're not a very attractive target, but they are being looked at, in the setting in upfront treatment. Coming to CAR T cell therapy, there is very limited data in infants, especially the high-risk group, the age less than 6 months. The main caveat being the process of the exhaustive process of manufacturing sufficient amounts of T cells. It's very challenging. So Qasim et al. Came up with a gene editing technique, which introduced the CD19 construct. So it is like a off-the-shelf universal CAR T cell product which can be used. So the main problem here being the biphenotypic nature of these rearranged leukemias and their ability and the lineage plasticity that they have to change from lymphoid to myeloid. And so it shows that they're not committed to their progenitor. So even the CRS that can happen due to high levels of cytokines like IL-6, which can induce myeloid differentiation. All these factors are challenges in using CAR T cell therapy as target. We are also there are groups also looking at multiple targets for CAR T cell therapy. So we come to an overall consensus recommendation made by Dr. Patrick Brown, Rob Peters. They are the main stalwarts who are behind the infant ALL treatment. Patrick Brown from the Johns Hopkins Institute and Rob Peters from the Rotterdam Institute in Netherlands. They have the largest publication of infants treated on ALL chemotherapy regimens. So they have suggested that for the low risk, there is not much confusion. They have an interferent induction, then the identical approach as per the existing pediatric ALL chemotherapy protocol regimens based on their genetics and MRD response. The intermediate group, depending upon their MRD clearance, as emphasized by even the interferent 06 trial. So the further intensive post-induction chemotherapy is based on their MRD. The main problem is the younger age and the rearranged population who have a late MRD clearance, which contribute to the infant high-risk infant population, in whom HSCT should be strongly considered. Hopefully, preferably a non-TBI based regimen and offered early if there is a matched donor available. Otherwise, continue consolidation and maintenance till HSCT becomes a an option. Thank you. I think that's my last slide. Thanks for your patient hearing. I'm happy to take any questions.
Thank you, Dr. Suma, for the lovely presentation. It's a very difficult topic, I guess, and excellent review what we have done. So we'll start taking questions one by one. I request all the panelists, please use the, can we just, yeah. So I request the panelists just to use the hand raise sign so that I can take the question one by one. And there are some couple of questions in the chat box also. So that I also take intermittently. So I want just one quick question that you just mentioned that predominantly the 3 protocol, right? COG, Japanese protocol, and Interfine. So what protocol you use in your practice, and what is the challenges you face in your clinical practice when you deal with infant leukemias?
Mostly, sir, the treatment protocols that I have come up with, all these cooperative groups have used, the induction is largely similar. There's no doubt that it should be a cytarabine-based induction. So we start with the steroid-free phase, await the MLL rearrangement report. And once it's available, things become easier then on. So the non-rearranged patients can be treated with the induction based on interferent induction, and then further risk stratification based on MRD. The problem comes with the younger age group, children who are less than 6 months of age, and that population who eventually end up being either in medium risk or high risk. So, and their treatment will be again based on time point 2 and time point 3, that is day 14 and the end of induction MRD, and then the further risk stratification based on MRD, and then an intensified consolidation, and then take it up from there. So I have not treated many infant ALLs. I've probably treated 5 in the last 7-8 years or so. They're not very common to even quote a data, but I have seen only one germline MLL patient who is currently on treatment. So I do not know how eventually he will do, but he is end of induction negative. But while I was at my previous training institute, we didn't have the HSCT as an option. So most of our MLL rearranged patients didn't do well. So I'm sad to say that none of them are alive. So in my current practice, what I try to do is to stick to probably the interferent O6 protocol and lymphoid-based induction and see how they do. So you have end of induction MRD if they're negative, and treat them on, and also look at the other cytogenetic features which might be seen along with MLL rearrangement. So if there are none and nothing like MLL markers like monosomy 5, monosomy 7, those are not there, then you'd straight away treat them on protocol 1B, the lymphoid-based consolidation, and then take it up from there based on MRD. And always look for a donor. Always have workup done for a HLA, either a matched sibling donor or, a mud search. Keep that ready as your backup. In patients who also have myeloid features, which are picked up on either cytogenetics or NGS or whichever study that you have done for genetic testing, look at post-induction MRD and then make the call. If there is a high MRD, they're more likely to do better on myeloid style of consolidation, and always keep HSCT as an option.
Thank you, madam. Dr. Amita, please go ahead with the question.
Thank you, Dr. Suma, for a very comprehensive overview of a rather difficult subject. You highlighted repeatedly, and the consensus recommendations also state to consider strongly transplant for the high-risk group. But when we counsel a family considering the challenges associated, with transplanting a baby, what really is the quantum of survival benefit? I know if we take into account the TRM, what really, how does one counsel and tell them that, well, if you opt for transplant, this is, what will be the difference in your overall outcome? I mean, because it makes us difficult to push for a transplant, even though the consensus guidelines say we should.
I
Because
agree.
at the end, what is really the quantum of benefit? That's, because you've reviewed everything. So
I think ma'am, when we look at all these trials and their data, it's the ideal setting, isn't it? And it's a Western, literature most of the time, and studied in a different type of population. Even among the interfant group, they looked at, because their cooperative groups and the institutions that enrolled themselves were placed over continents. So the Western, mainly the North American and Western Europe, did better compared to the other groups among themselves. Among the Caucasians themselves, there was a difference in outcome. So in our population, I completely agree with you. It will be very difficult to even push parents to take this as a viable option when there is an availability of a donor. But I think if there
they
is a
may
match,
be prepared to, but they may ask, well, what is exactly, obviously for a child, it doesn't mean anything, but really what, survival benefit would this option give us? I mean, would we say 10%? Do you think that's a reasonable number?
so
Or maybe
in
more?
the MLL-10 trial, which offered a transplant much earlier for these patients, they found a jump of 20 to 25% if the transplant is offered within a median of 4 to 6 months. So that's a significant difference that you can see compared to the other cooperative groups. So I don't know if that answers your question.
Yeah, no, that's fair.
Thank you. Dr. Rajat, please.
Oh, yeah. Dr. Suma, a very nice presentation. I'm just following Dr. Mahajan's question. I'm just going to give you a perspective of what I have seen. So during my UK training till 2010, we used to use Interfant 06 and too much toxicity. Patients will stay in hospital months and months. And I have seen children being cured with transplant, but too much toxicity. So then I moved to Canada, and they're using gastrostomy-based therapy. Again, too much toxicity. And so when I came back to India 2011, I had a story to tell. My first child was a 4-month-old baby with a white cell count of 400. And a very resourceful family. So I told this family that this kid needs treatment, but they refused, or rather they asked me for the opinion. So I emailed everybody across the world, all the experts, including Revati Raj. So everybody, Western world said, yes, we will treat this child because that's what I've been trained. Revati said, do not treat. These children are not salvageable. So we didn't treat the kid, and it passed away. Then I came to Singapore, and a similar case for a 4-month-old kid with a 400 white cell count. I said, I want to use Interfant protocol, and they all say, do not use Interfant protocol. Our children, these Asian children, do not tolerate that. So we just use the Marksburg 2003 protocol, which is just standard ALL treatment. And based on whether their MLL KMT2 rearranged or not, then we use a high-risk protocol. And then if they are less than 6 months, if they MLL rearranged, we take them to transplant. So my first kid, so I just used a standard, and that's what we have been using, a standard ALL treatment, BALL treatment, and based on the age, less than 6 months, and KMT2 rearrangement, and also the MRD. We didn't decide whether to transplant or not. And that kid, I first started, is now in 6 years post-transplant in complete remission. And we have followed that thing. So Interfant ALL is actually, she's a misnomer. You should just go with the cytogenetics and your genetic things, not the age. Age cannot be. And so the youngest one I've treated is a 6-week-old. Again, 4-11 translocation. And the only long-term side effect she has is a vincristine-induced neuropathy, which happened in the first month. But otherwise, she's cured. The issue with the transplant, to answer Dr. Amita Mahajan's question, with the transplant, the toxicities are significantly less nowadays. So during transplant, it was a sibling transplant. So I asked around, and Percy Sabrolia from UK gave me the data of the infant ALL and said if you use flu-trio thiotepa-based conditioning, is actually very well tolerated. So transplant conditioning has significantly improved now. So what is available on the literature is not applicable in the current state. So I would say the most important, I think, message to take is look at the KMT2 rearrangement, and on the infant ALL 06, infant 06 trial showed those who were younger than 6 months but KMT2A germline, they had actually 90% long-term disease-free survival. So that is the most important thing. Don't just discard them completely. We have several kids now, I think 4 less than 6 months, high white cell count, but KMT2A germline. First patient, I said to the parents that they need transplant, and then I had to just eat up the ward because it was MRD intermediate risk. So we just carried on treatment and in long-term remission. So I think based on the cytogenetics, on the features, and all the age comes in, and most importantly MRD. I think so. The significant proportion of these children should be treated, and even the younger, they can be cured just with chemotherapy. But taking to a transplant using a less intensive treatment protocol, and especially if you use a haplotransplant nowadays with these immunological transplant, you use the immunology, the donor cells to kill leukemia cells. I think we can cure them. So that will be my take-off.
Yeah.
Thank you.
Thank you, Dr. Rajat. Dr. Richa, please.
Yeah, hi. Thanks, Dr. Suma and Dr. Rajat for your comments, actually. I was going to ask something pretty similar to what Dr. Rajat has already expanded on. At PGI, we see a reasonable number of infant leukemias. As mentioned, not all of them are MLL positive. The ones who are MLL negative do reasonably okay on the general ALL protocol. The ones who are MLL positive, we have not really had experience using Interfent. It's very toxic. So I wanted to ask you and the other panelists what is been their experience with toxicity, with tolerance, and whether any modifications are carried out while using Interfent is one. And second, in continuation of what Dr. Rajat has just said, the ones who are intermediate risk, MLL positive, but becoming MRD negative, we have not seen them do very well on the standard ALL protocol, to be honest. The ones who are negative and are low risk, they do reasonably well like any other population. And another question I wanted to ask you and the other panelists was whether there has been any experience using blinatumomab in our country with in these patients upfront or in a bid to induce remission once they relapse. So, thanks.
I think a large part of it is to do with supportive care. We cannot discharge these patients early at all. I think most of them end up staying for 6 to 8 weeks, especially once we initiate the cytarabine part of the chemotherapy, the pancytopenia that would come after that, and that can end up in a lot of infections, fungal, bacterial, everything. So they end up receiving a lot of blood products, supportive care. So I think if we are able to provide that and the patient is able to afford the same, more or less they can be treated. Toxicities, induction as such, infection is the killer, if at all. Otherwise, mostly these patients can be brought till remission. I do not have any experience in Blina. I haven't used I've seen only 7 patients, so I have not used Blina for any of these patients. Maybe Dr. Rajat can answer.
And do you modify the protocol, the Interfent at all, or do you give it as such?
We did. So for a couple of patients, we couldn't finish the 14 days of cytarabine.
Right.
So one of them received only 8 days, and we had to stop because it was, the child was having continuous temperature, and the platelet was just, we were transfusing twice a day. So only one patient finished 14 days of cytarabine. So modifications definitely do happen because the first week chemo, the vincristine, Dono has gone. So what you can play with is only cytarabine. That comes after that. So that is the only thing that can be, decreased or given according to the plan. Pegaspigenase or elaspigenase, whichever has been used, is largely well tolerated. So that we do not dose modify. The only dose modifiable drug is probably cytarabine.
Right.
Yeah, Dr. Rajat, regarding
Sorry,
your
yeah,
experience.
sorry. I also not have used Blina in infant ALS, but now that we know how to use Blina better, if you use it on a very low level, MRD level, probably you will not see much toxicity at all. So don't use it with a very frank leukemia, then the toxicity will be higher. If you try and bring it down and then use just as a bridge to transplant, I think that'll be better. So toxicity will also be less. Use in MRD setting rather than with a frank a lot of blood cells.
Thank
I mean, the only challenge, I mean, Dr. Ajay Vora's experience is, I think, the largest experience with blinatumomab in infant ALL. But the one challenge is that it's not expressed very strongly in most patients with infant ALL. And that's again the challenge with inotuzumab, because for us, cost-wise, that would, and considering the size and weight of the child, that would be a very attractive option. But they do not express CD22 very strongly. But definitely we'd like to, I'm sure we will see more of immunotherapy in infant ALL, because traditional chemotherapy, I think we've got what we could have got. What about azacitidine? I mean, in our setting, could we look at just, getting azacitidine, bortezomib combination to at least get them into remission maybe, and then,
Bortezomib, the St. Jude's,
or like a pro phase, so that the toxicity of treatment is, which bogs us down.
I think the Tata TMH group is already using bortezomib in their induction in India, I think. I mean, please correct me if I'm wrong. So, but then St. Jude's, the trial is closed. They're not recruiting anymore. I think very soon we'll get the results as to the combination of vorinostat and bortezomib added early in induction itself, if it made any difference, because they can be useful drugs in an Indian setting. Yes.
Thank you. Dr. Anand?
Yeah, thanks for an excellent presentation, Dr. Suma, and the very good overview. My question is related to what you spoke about in the first part of your talk regarding the genetics and how we diagnose infant ALLs in terms of and the other cytogenetic markers. So now that we have NGS available for most of our acute leukemias, from your review, have you seen any markers which would give us, besides the MLL positive versus negative, which would give us some sense as to how to counsel these families to decide on taking therapy?
So we can get these results as early as day one, because if your lab has NG2 in their flow, the same day you know that this NG2 is like NMIC and ALK. So if NMIC is there, ALK is probably there, like in neuroblastoma, similar. So if NG2 is picked up on your flow, that means this patient is most likely going to have MLL rearranged, given a scenario of age, of course, not in a older child. So, but FISH as such has a faster TAT. So the counseling becomes easier, and they would be still in that steroid prephase within which you would be.
My question was not with the MLL positive or negative. FISH is relatively quick and we get it within 24.
Yeah.
My question is more is with, we know age, white cell count, and MLL positivity and negativity gives us a sense as to, how these patients are going to do. And that is played true across the world. We've all had patients above 6 months who've had MLL negativity, and some of us have used less intense protocols and they are long-term survivors. So we've had that experience. I'm talking about the type of patients where they are MLL positive, they are less than 6 months. Do we have any early NGS evidence from your review to tell us, these are patients who are worth treating in our setup? Because a lot of the families do, when we say 30%, 40%, 50% survival, they do struggle with that initial decision making of whether they really want to go ahead with the treatment. So from that perspective, thank you.
No, I do not have much. I didn't look at that particular topic as per what you mentioned in my whatever literature review I did. Maybe the other panelists can throw some light. But what I have understood from whatever I studied is that as the age is lesser, more common is 411, and that alone itself is a bad prognostic factor. I don't know if anything else is required to make it worse. So the especially the 2 to 4 months and 4 to 6 months age group, 411 is the most common translocation, and closer to 90% of infants have them. So that alone is probably a deciding factor. So NGS, if it would add any more information, I'm not aware. I will look into it and get back to you.
Sure, because I think there was work done on FLT3 and FLT3 inhibitors that didn't really play out in terms of any improved survival, at least so far.
So the problem with FLT3, as I was mentioning, is it's not a FLT3 ITD mutation that happens in these patients. It's just the increased expression. And most of these patients at remission, it is lost. And then even if they relapse or have progressive disease, it doesn't reappear. So that exactly is not a attractive target to continue post-induction treatment. So I think the 0631 trial has proved that the drug as such is not an attractive thing to use. Yeah, rather it didn't contribute to any improved outcome.
Sure. And to add a point to, I think, the discussion on transplant, I think there is general consensus to say that the groups of patients with infant ALL who ultimately reach transplant are different from the ones who don't even reach transplant because they have such an early relapse. So this was a challenge we faced at SickKids and we continue to face at St. John's. In terms of, yes, we would have counseled the family regarding transplant, but the relapses, they won't reach. So the ones who actually reach transplant and who are so-called survivors post-transplant, we are probably not yet sure. I'd like to hear from you and the rest of the discussants, whether there are some markers to tell us that, yes, it's really worth going all the long haul with transplant. Are we selecting out those who are relatively less, bad infant ALLs and transplanting them and then thinking that, yes, transplant has actually helped us? I'd like to hear from you and the discussion. Thank you.
I agree. The same has been noticed in most of the cooperative groups. The ones who died were all within the 1 year of diagnosis. And deaths in CR mainly were the causes being infection and so on. The second most common cause was relapse. So the post-induction consolidation that is given in different cooperative groups, it varies. So that consolidation has to be really intense. And how many children actually survive out of that to live up to transplant, that's a problem all cooperative groups have faced. Even when there is an available donor, that would be a real tragedy.
Thank you, Dr. Anna. Dr. Anna, I will take the questions later. Dr. Arora, please.
Good afternoon, and thank you, Dr. Suma, for a very nice presentation. My question is that when you have reviewed the literature and you showed the COG and the inter-infant and the Japanese, did you find published data on India, from India, Indian experience? What has been practice? What has been the outcomes? And a wider question, because I can see Samir, Venkat, Nihar are all here who are part of the ICICL group, is considering the rarity of the disease and the challenges it poses, and the fact that the people over here who themselves are seeing so few numbers, is that a recipe for doing some work collaboratively within the Indian context? And that is my belief for the Indian Pediatric Hem-Onc group. Thank you.
I didn't find much data. No, probably Dr. Niharendu would know more. I don't know if they're considered in the ICICL, and I do not know if they're a part of the, they're like picked up on ICICL, whether they're being treated on the HR arm, I'm not aware.
So they're not part in the ICICL study, but the ICICL is a consortium, right? So within the INFOG structure. So that is where I was coming from. Thank you.
Dr. Chetan?
Yeah, yeah. So excellent presentation, Dr. Suma, and a very good discussion. So at Tata, basically, our ICU is not really geared to handle infants. So at TMH Mumbai, we were not treating infants so far, but now we have started treating. We have had a little bit of experience on that. We have a few survivors that were treated previously, but most of them were more than 6 months old. And some of them did have MLL rearrangement. We treated them on the icicle-like backbone, the MCP-841 protocol, which has high-dose Ara-C, 2 gram per meter square twice a day for 2 days. So that is where I think we have tried to treat them and give them Ara-C-based conditioning. So some of the survivors might be because of that. But basically, infection predominates and infection-related mortality is very high. So we are also not very keen on really treating these patients. We treat only if we can provide them some transplant in the long run. So if transplant is a possibility, if family is motivated enough, only then we would go ahead and transplant these patients. Having said that, I concur with Rajat. So when I was in Singapore, we had a few kids, infant ALLs, whom we treated. The crux was early transplant rather than increasing the toxicity by giving more and more chemotherapy. So that transplant within 4 to 6 months of diagnosis was the crux of getting better outcomes. That's what I feel. And again, the treatment was a high-risk BFM backbone and nothing more. So that's what I feel was on the MASPOR protocol. We felt that those outcomes were at par with the published literature.
Dr. Chetan, I have one quick question for you.
Yeah.
So what is the incidence you see in your TMH yearly incidence of the infant ALL?
So every year we get around 5 to 6 kids that come to us, but generally we have been sending them over to Wadia Hospital because that is where the pediatric ICU is well equipped. So around 5 to 6 kids a year, that's what I would say. And there might be a referral bias.
Yeah, thank you. Dr. Niharendu?
Hi, thank you, Dr. Suma. I think I try not to speak much, and twice I've been forced to talk in FOPON, and I'm very happy.
Sir, I must say, I think I've stolen most of your slides.
I'm so pleased that actually I could get somebody to.
I have listened to your talk, while I was wherever I was driving, and I was like, okay, what would have Dr. Niharendu, looked at when he said this? So my entire talk is a complete inspiration from whatever you spoke.
Thank you so much. I just wanted, I was trying not to speak today either, but with the different points that have been raised by the various panelists. So it's a couple of things, or rather my experience back here as well. The first point, again, Dr. Richa expressed that view that infants, they are not treated. That was exactly the opinion when the first patient that I wanted to treat in Kolkata. Anirban, who's from the same institute as Dr. Richa. So he almost looked at me with unbelieving eyes. You're going to treat an infant. And the problem is I came from a center which treats all infants in the whole area of London. So anyways, that was the beginning of it. And in terms of the interfront business, so the question that I'm trying to take is that question of what to use. Now, in terms of using the conventional chemotherapy, it has been proven again and again that overall survival of using even high-risk ALL treatment doesn't give you an overall survival beyond 20 to 30%. So they will relapse fairly quickly. I think what Dr. Rajat and Dr. Chetan are saying, I think if you're lucky, you will get some of these patients who will not relapse, but vast majority will relapse. And that is definitely the reason why we need to think ahead and think of slightly more innovative strategies that we can offer and that can be affordable. The next point is the question of the modifications. So the first patient that I treated here in Kolkata was interferon based. The family was affording, but again, the same problem that we had faced elsewhere is that that's the same problem that everybody has faced: the toxicity, the cytarabine based mucositis, and the need for supportive care, need to stay in the hospital for 2 to 3 months. Even in London, that was exactly the case. So that is not something that our families can afford. And that was the time when we started looking at other strategies. And that's when we got interested in the TINI trial, the one that Tanya Gruber's team is doing. So personally, we have actually modified some of it and still in the part of modification. The only reason why I'm bringing this up, I'm not saying that everybody should adopt that. And I take that point from Dr. Arora, and this question of how many patients do we have? And I tried to get this data. And that was the reason, I think Chetan would remember that I had given him a call. The reason for that is the person, Dr. Anindita Roy, whom you would see a lot in any of these biological studies that you would see. Actually, she's somebody from India, and she's possibly one of the doyens in the field of infant ALLs, the biological studies. So first, one of the first things that she had asked me was, how many do you get and what is the data? And then we could set something up with the UKMRC. And the first person to go to would have been TMH. And I knew what I had, and I did not keep all the data, but we realized that none of us actually have kept our data. If we did not keep our data, then obviously nobody would publish it and nobody would know how many patients do we get. So yes, we do not have the data. I think in the last, in 2021, I think possibly we have had 6 or 7 patients who have come with infant ALL, but we do not have the data. So that's one of the answers that we do not have an answer to that. The next question is in terms of the modification of therapy, it was quite amazing. We picked up a bortezomib-based therapy with mitoxantrone. Initially, 2 patients we could give panavinostat that we stole from the adult team, which we were getting as a compassionate access because we did not have vorinostat. We tried to get in touch with the company which produces romidepsin. It's quite surprising that the romidepsin actually has got the highest sensitivity amongst that group of drugs. That is actually made in India, but not sold here. It goes abroad. And we tried to nick some of that. We didn't get that. So that part, for the time being, the HDAC inhibitors are out of the way. But by the use of the bortezomib, mitoxantrone arm, actually I have been able to send my patients away within 10 days of their getting admitted. So our inductions happen most of the time with the patients outside the hospital. So for me, that is the biggest achievement that I had. I do not have a lot of patients who have gone through. So I think the 4 patients are possibly going through it. 1 patient is possibly with this modified therapy. But thankfully, they have not required as much supportive care as I was facing with the Interfant. And that is possibly the push for us to try and use something different. I'm also quite inclined to use venetoclax now that it's available through the gray market. And I think by the end of this year, we would possibly get venetoclax available in India. I think Zydus is going to produce that. The problem with, or rather, I wouldn't say the problem, we have used it in the DI phase in these patients. So when we have gone through this, and in DI, we have added it when the marrow is slightly more recovered to give less toxicity to these patients. And they have actually tolerated this therapy fairly well. In the recent COG trial, they are actually using the venetoclax way ahead. So they are starting from induction. But for our patients, that will be a challenge, trying to give all this therapy, the amount of toxicity that they will get. That is we are slightly wary of that. But I think at some point, we'll have to think about it. Bortezomib, they have very well tolerated this drug. The initial challenges that Dr. Mahajan was trying to raise, I think the biggest challenge that I face is a 6-month-old. They would come with 600,000 count or 700,000 count. plus or minus CNS disease. Good number of them would have CNS disease. Trying to control the TLS, trying to get in a line in time. If I have to, for a 6-month-old, trying to put in cannulas every 2 days, it's not a feasible solution. Or trying to do 4 TLS in a day or 3 TLS samples in a day is impossible. So my first challenge is in the first 7 days, trying to get in a line, trying to give them the supportive care that they need. And I think nowadays, I think the question of the 7 days of prophase possibly doesn't exist as such, for the simple reason that in the situation where we have got better MRD, as in West or possibly in Singapore, or possibly TMH better than us. But I think that gives me some time to reduce the disease before we can get in there. BFM at some point had said the prophase, results of prophase or 7-day prednisolone response was possibly one of the biggest indicators, possibly, which is not true in today's world when you have got MRD. The problem with the MRD is now everybody is doing MRD, but we do not know the validity of those tests. We still struggle when we are trying to do MRD when we are using flow, because in the best of the centers, it's difficult to distinguish the hematogones from, particularly in infants, a 6-month-old or an 8-month-old. It becomes very, very challenging, and that we have seen firsthand. Then the question comes, does it need to be an RT-TCR or an NGS based, which in West you could do. The problem of using, so the better situation, the one that you described, the question of using molecular, the 411, 911. The question is, like you said, that you have got 42 or more than 40 partners of the chromosome 11 translocation. So you cannot develop TCRs for everyone. So that is the challenge. If you have a 411, 911, you can possibly develop a PCR, which is you can afford to develop a test at a particular center, unless you are doing it at a central center for the whole of India, where you can do it together. So those are the challenges that you will face. The validity of those MRD results in an infant less than a year old, trying to tease out which ones are actually hematogones and which one is actually true positives is difficult. And the other question,
Dr. Zara, just there's a lot of other questions. I'll just give you a chance again.
Yeah, sure.
Yeah. So there is another question from Dr. Viva Bhakna, that what are the tests to differentiate between germline and MLL rearrangement? And in MLL rearrangement, do you transplant even if they are MRD negative? Shall I repeat the question?
Sir. So a good FISH analysis with the dual break apart probe initially to figure out if there is a rearrangement or not, and then the dual color dual fusion probe for specific translocations. They are easily available. In most centers, they're available in a good cytogenetics lab. So that should not be a problem to differentiate the germline and rearranged MLL leukemias. What was the second question, sir?
So second question, in an MLL rearrangement, do you transplant even if they are MRD negative?
No, as we were, as I was just showing the flow chart with the different cooperative groups, if they have achieved end of induction MRD negativity and they continue to be negative at different points in time, they can be salvaged. But if there is a suitable matched sibling donor, and this is a high risk group, age less than 6 months, and in them, it's better to look at transplant as an option. The older the age group, they can be treated with chemotherapy.
So another question from Dr. Anand Prakash. For infants more than 6 months, MLL negative, CD10 positive. So what is the survival with standard ALL treatment?
MLL negative and CD10 positive.
Yes, and patient 6 months older, more than 6 months.
They can be treated like on the current available standard chemotherapy regimens. And they have an EFS, I think 4-year EFS of more than 75%. They do well.
Dr. Rajat, your question?
Yeah, I almost forgot my question. Oh, sorry. Yeah, there's a comment for Anand's previous question. I think you have to weigh what is there any other features you can say from the beginning? This kid is a very high risk of relapse, and can we decide which one to transplant? I think I saw some literature about which fusion partner. The 10-11 was the best one, and the 9-11 was one of the worst one. But I think which other fusion partner apart from MLL, the KMT2A is causing trouble. I think you have to wait for Tanya Gruber's study to say which is causing trouble, and then target that region. In Singapore protocol, we have now 42 infants. So we've treated in the same protocol. Our event-free survival was 56%, and overall survival was 72%. Using just a standard BALL protocol and then using transplant much earlier. We are going to do an RNA sequencing on 35 samples we have to find out which is there any fusion partner or anything, any other mutations are adding on to the KMT2A to cause it. So I think the answer at the moment, we don't know. But we felt in Singapore's experience is that the less than 6 months and MLL KMT2A rearrangement, we usually just take them to transplant when they're MRD negative. Question is how we get the MRD negative is, you have to just try and give the standard chemotherapy. And if you need, then obviously blinatumomab will be your first choice. Yeah, thank you.
So one more question from the chat box. Dr. Tejashini, ma'am, how to monitor blinatumomab toxicity in infants, given that we monitor handwriting in adults?
I do not have any personal experience with blina. I mean, if there's any of our panelists who have used blina in this specific age group.
I think Dr. Richa has already answered. There is a validated question. Yeah, she has answered.
If I may answer this question,
sure.
Is this same? I wouldn't say exactly the same, because for adults, again, my N equals 1 in terms of an infant in India, in Calcutta, who was a non-MLL. But by the time we were doing it, I think it was beyond a year old. It becomes slightly difficult when, but yes, it is feasible. We used St. Jude's, I wouldn't say questionnaires. For every shift, you monitor them, looking at this particular characteristics, but that can be done. It's not too difficult.
Yeah. So any more questions?
Can I have one more minute?
Yeah,
sure.
Can add something. Yeah. What is coming for the input?
So I think the question about the transplants, I think the transplant, one of the problems is, if you look at the Japanese group, I think the way they could make it much better is by using, so obviously for infants, you are not using radiation. So you are dependent on either a busulfan or triosulfan. The way the Japanese made it better was by using the right dose of busulfan, for which you need the drug monitoring of busulfan. We do not have enough labs in India which can monitor it very well and can predict that. So the second question that Dr. Rajat had said, that the use of FTT, yes, FTT has been used. The question is that will be used if you have possibly a matched sibling or a matched unrelated donor. A good number of them will end up having a haplodonor. That is the one where I'm struggling now. So anyway, so those are the things that we'll have to keep in mind. Without radiation, busulfan, we cannot measure very well, and haplodonors.
I'd just like to make a comment, if I may, sir.
Sure.
So I think as other disease paradigms have shown us, the matched sibling versus unrelated versus haplo question, I think, will not play so much into the survival, because at least the early data from AML transplants at various ages have shown that haplodonors do as well or sometimes even better than matched sibling. But I think the challenge remains in getting these patients to transplant, because keeping them in remission and making sure that they're MRD negative is clearly important prior to going into transplant, like older children with ALL. So I don't really think that, yes, of course, matched sibling donor transplants would historically have a better outcome in any disease setting. But I don't think that really will play into the algorithm when we choose donors. Thank you.
So any more questions? I think Dr. Suma, it's an excellent presentation from you, and it's a fantastic interaction. And I guess it's a very difficult topic whom you actually were practicing. I'm an adult one, so I don't deal with infant ALL anymore. So it's excellent, and thanking to all the panelists for the excellent contribution. Kalpesh and his team, Perfect Square, for the flawless logistics. And thanks MCure for assembling us in this beautiful virtual meeting of MHG. Thanks a lot. Have a wonderful day today.
Thank you so much. Thank you.